the drugs that were used 20 years ago are very different than the drugs that are being used now. The potency is much higher. The effects on the brain are a little bit different. So the brain in recovery now is very different in the challenges that it faces compared to the brain that was using 20 years ago. Medication-assisted treatment, or MAT, is medication that helps stabilize the brain for people who suffer from various types of substance use disorder. It also needs to be stabilized in regards to craving so that the brain can start to return to functioning more normally. We would not shame someone for taking insulin, and we shouldn't create stigma and shame for people who have this chronic medical condition.
Welcome back to The Complete Reset with Dr. Quinton Moss. Over the last few episodes, we've talked about addiction as a brain-based condition, not a moral failure, and why mental health and substance use really must be treated together. So today, we're stepping into one of the most misunderstood and emotionally charged topics in recovery, medication-assisted treatment, or MAT, as a lot of people tend to call it. So for some people, MAT represents hope. For others, it raises fear, confusion, or even sometimes resistance. So today we're really breaking down what MAT actually is, how it works in the brain, who it helps, when it's appropriate, and why, for many people, it dramatically improves outcomes and saves lives. I think that this is such an important conversation, especially after the last few that we've had, and I'm really excited to get into it. So it's a pleasure seeing you again, Dr. Moss. How are you today?
Doing well. It's great to be back here with you. How are you today?
Good. I'm excited. And I think that this is such, like I said, important conversation. For me, it's super important because this is something I've always been a little bit personally invested in and interested in really learning more about. So I'm excited. So let's just dive in. So, Dr. Moss, when people hear medication-assisted treatment or MAT, reactions can be very strong and, from what I think, also a little bit mixed. So at the most basic level, what is MAT and what is it not?
Medication-assisted treatment, or MAT, is medication that helps stabilize the brain for people who suffer from, various types of substance use disorder.
Mhm.
The brain needs to be stabilized oftentimes from withdrawal, which forms of MAT are able to help with that. But it also needs to be stabilized in regards to cravings so that the brain can start to return to functioning more normally in how we prioritize, how we think, and how we process. And the medications allow the brain to be able to do that.
And from a brain science perspective, why does medication play such an important role for many people with substance use disorder? And what does medication help stabilize that therapy cannot often alone really stabilize?
hmm When you think about, the targets of psychotherapy, whether we're talking about individual counseling or group counseling, we think about intensive outpatient programming or partial hospitalization programming. Those techniques are used to actually affect the prefrontal cortex, where we make decisions, where we're able to prioritize, where we're able to process, right? And that allows for us, hopefully, to be able to interpret what's going on around us and make the best call about what our response is going to be. The medications that we prescribe actually target centrally where we have our degree of reward, pleasure, which is the attack site for addiction or substance use disorder. So if we were to go deeper into the nucleus accumbens, we think about that portion of the brain, big word. There are neurons or cells that have certain receptors. And there are a number of receptors that are associated with, mental health concerns, chronic diseases. But there's one in particular that shares, a couple of conditions when we think about alcohol use disorder, Think about cocaine use disorder may actually have some activity there, but for sure, opioid use disorder has activity, and that's the mu opioid mu opioid receptor, mu receptor. And this receptor, it actually attracts and engages with our natural, system of soothing and comfort, which are endorphins, and is
Okay.
able to engage there, and we are able to, experience pleasure. But when we take outside substances, like pain medication, narcotic pain medication, or we're talking about fentanyl, or we're talking about heroin, morphine, when we take those outside medications or substances, they actually attach to that same mu opioid receptor, and we get this release of dopamine. And that release of dopamine can cause significant amount of euphoria. It can help people feel less anxious. For some people, they may feel less depressed, but it creates a habit forming mechanism where people have to end up over time take more and more and more to get the same effect. The medications that we prescribe also sit at that same mu opioid receptor. And what it does for some, it helps with withdrawal symptoms. So
Mhm.
for people who are acutely in withdrawal, certain forms of the medications helps to subside those withdrawal symptoms so that people can normalize. But it also helps to reduce cravings. And cravings are a big issue, a big challenge when we think about substance use disorder. So think about a thought that becomes so intense and thinking about that substance that our body starts to respond to that. Whether we're feeling like we're going through withdrawal or we have other body sensations that have been heavily impacted by this particular thought. The medications, when they're able to stabilize that mu opioid receptor, people are able to have less cravings for alcohol, less cravings for opioids. And for some people, this helps, with cravings for things like cocaine and also possibly methamphetamine. But that's how these medications work. Without the medications, when people have cravings, these cravings are able to send projections to the prefrontal cortex where we think, prioritize, and make decisions, and that area gets hijacked such that we start to make the wrong decisions. Things that really aren't important become super important surrounding our use, secondary to our cravings, and how that particular area of the brain, the nucleus accumbens, sends projections to the prefrontal cortex. Medications we prescribe help stabilize that to some degree.
And with that, is that particular to a certain substance more so than others, or is it overall with really all substance abuse?
So, from the studies that have been conducted and from what the FDA has approved, we have medications, MAT, that treat people who suffer from alcohol use disorder and people who suffer from opioid use disorder. So, addiction to fentanyl, to pain pills, morphine. We have medications that are able to target those specific conditions.
Okay, interesting. And this is probably a question that's common that you get a lot from families, but how is Matt different from continuing the addiction? And beyond that, how do you really explain the difference in a way that is honest and clear and even really digestible to families?
Yeah, that's a great question because I just mentioned that whether you're using a substance or I'm prescribing a medication, I'm having activity often at the same receptor. So
Exactly.
when we are acute or we are actively using with this chronic illness of substance use disorder, we have the risk, of course, of using too much. We become preoccupied with trying to retrieve it, often retrieving the substance in very dangerous or illegal ways. When we're using the substance, we're placing ourselves at risk for other medical conditions, including endocarditis, cellulitis, HIV, hepatitis C. Our day is really built around trying to obtain that, not to mention the lethality. There's lethality or risk of death with ongoing drinking excessively. There's risk of death with, any time that someone is using any form of opioid. So when we have folks who are still actively using, those risks are there. When we prescribe medication that allows for people to have their withdrawal symptoms and their cravings stabilize, not only do people make better decisions and they're able to start getting to the routine of their regular life, but we're reducing the risk of overdose. We're reducing the risk of catching or transmitting, certain diseases or infections. And so the risk of ongoing complications and death are minimized when we're able to appropriately prescribe MAT to clients.
Interesting. And you mentioned, for example, you threw out HIV and hepatitis C as examples. Are those just some of the illnesses and diseases that are common within drug abuse scenarios? Or is that the reason? Mm.
So they're common in people not only who have opiate use disorder, methamphetamine, I think people who struggle with that, but also people with alcohol. And, depending on the substance and how it's used, particularly for folks who are injecting, there is the risk of hepatitis C and HIV. And then for people who have certain behaviors surrounding their substance use, it places them at risk for infections.
Got it. Interesting. And can you give the listeners, I guess, maybe a high level overview of really the main met options? Like, for example, methadone,
hmm
Suboxone, Vivitrol, or anything else maybe I didn't mention, and how they really work differently in the brain.
Okay. Maybe let's start with again how the opioid again engages with that receptor. When someone is using or taking a pain pill, it engages with that receptor and it causes this flood of dopamine. So people feel euphoria, intoxication, sometimes less anxiety, sometimes less depressed temporarily. That's what folks experience. When we prescribe methadone, methadone has a lot of stigma associated with it. People, look at a methadone clinic and they may think about lines outside and people going in to get their medication daily. But we have probably some of the strongest evidence as far as people being able to be maintained well with methadone. When people take methadone, it sits in that same receptor and it causes such a satisfaction that it reduces the cravings for people want to use other things. So the likelihood of them going out to use other things on top of that is dramatically reduced. And so it's been one of the most effective treatments that's provided in the space of a substance use disorder, but it's a full agonist. So what does that mean? That means that it fully engages that receptor, right? Which allows for it to, have a significant release of this dopamine. People who tend to do well with methadone are people who are struggling with withdrawal and it's hard to get on another form of MAT. We can get folks on to methadone pretty easily. People who have severe pain syndromes or pain conditions and they need their pain managed while they're trying to manage their substance use disorder, methadone is also a great option. And for people who really want a heightened level of structure and supervision surrounding their care for their substance use disorder, the methadone is also a great option.
Mhm,
Now, if we were to transition from methadone, next would be buprenorphine. You mentioned Suboxone, right, which is
mhm,
a form of that. We are able to prescribe this medication, which also affects that mu opioid receptor. The challenge with starting this medication is that if people are actively in use and if they've used within the past 24 to 48 hours, if we were to give them that medication, they may actually get a bit sicker before they get better. They may actually have worse withdrawal first before they get better. So we have to be careful about how we place someone on this medication or how we may do an induction with that medication. But a medication works a little bit different. It sits on that same receptor, but instead of being a full agonist, which is going to allow for it to sit there and have this release of dopamine, It does a little bit of that, but it is also a blocker.
Okay.
So if you use buprenorphine and you are taking that and you try to use on top of that, oftentimes you won't get much of an effect, or you may actually make yourself sick with withdrawal if you were to try to use on top of that. So that's how that medication is a little bit different. That's a medication that's dosed once a day. Some people end up taking it 3 times a day, kind of spread out the dosing. People can have this at home. They can get a 2 week, 1 week, or a month supply that's being managed. So this is more commonly the way that we've been able to address this condition, probably more so over the past 15 years. But
Oh.
one of the things that's great now about this form of treatment is it now comes in the form of an injection. So now we can have an injection of this buprenorphine, and we can have an injection that lasts for a week, or we can have an injection that may last for a month. And so people don't have to worry about having to take a medication each day. They just go to the healthcare provider and get the injection, whether it's going to be a week or a month, and they're stabilized for that period of time. So that's an awesome thing in the field as far as being able to have a long acting injectable medication for treatment. Now, if I were to transition, I will talk now a little bit about naltrexone. So I talked about how the other medications, they affect the mu opioid receptor. One of them sits in there and fully engages. One engages and it blocks. The naltrexone actually just fully blocks. So it sits on that receptor and it doesn't allow for any opioids to engage with that receptor. And it has a way of still reducing the cravings to some degree. But in order to be on that medication specifically for opioid use disorder, people have to be detoxed or have received medical withdrawal from, the substance, and then we can introduce naltrexone. Naltrexone also has a long-acting formulation, an injection that can be taken that lasts for a month. So there's some versatility there. So we have some great tools from a medication standpoint for MAT to help people with opioid use disorder. Now, Layla, if I were to transition now to alcohol,
Mhm.
alcohol also affects that same mu opioid receptor. That being the case, we're also able to use naltrexone and Vivitrol for the treatment of alcohol use disorder. So there's a pill that you can take every day, but how many people are compliant with taking a pill every day? Neither of us probably take all of our medications all the time.
Right.
It's easy to have an injection. And so there's an injection that people can have once a month that reduces their cravings for alcohol and it reduces the number of days that they might actually drink over the course of a month. So that's the beauty of that. There are other medications that we can prescribe for alcohol use disorder. Acamprosate, formerly known as Camprala, is another medication that you can take 3 times a day to help reduce cravings. And Antabuse is another medication that we sometimes prescribe. And with that medication, if people were to take it and drink behind it, then they would feel very uncomfortable or get a little sick. So those are some of the treatments that we have for, alcohol use disorder and opioid use disorder, which are the only conditions for which we have a form of MAT or MAT to be able to treat. The other substance use disorder, not so much. We have to come up with combinations which may be helpful for some people.
Absolutely. And you've talked about methamphetamine, and you've been very clear that methamphetamine use disorder is different from
Yeah.
opioid, or like you also just mentioned, alcohol use disorder. So why doesn't meth look the same for meth? And how could expectations for recovery be adjusted?
People who suffer from use of methamphetamine, are, they suffer from a number of different mechanisms by which this substance affects the brain. So we talk about this mu opioid receptor, and that's the main mechanism that we think about for alcohol and for opioids. But for methamphetamine and how it attacks the nerve cell or the neuron, it does it in 3 or 4 different ways. Not only does it attack a receptor directly, but it enters the cell and it cuts open the stores of dopamine so that they flood outside of the cell and cause increased transmission. The dopamine that's outside the cell that's usually recycled, that process is stopped. So we have this super abundance of dopamine, making methamphetamine use a more compulsive disorder. And people struggle a great deal more, not only just with the intoxication, some withdrawal, but also a lot of psychotic and mood symptoms associated with it. We don't have a medication that directly treats this condition. There have been studies that have shown that perhaps if we give someone a certain antidepressant, bupropion, formerly known as Wellbutrin, if
Yeah.
we give them that in combination with Vivitrol, we notice that people are able to go longer periods of time without use. So that's one of the recommendations that we can provide is this combination again of Vivitrol that we previously talked about and Wellbutrin to be able to treat. There is some evidence that a seizure medication called topiramate or Topamax, may be helpful. Some people believe that naltrexone, the pill version, of this Vivitrol may be helpful, but not a lot of strong evidence to support that particular medication or a combination of medications to be able to help people who suffer from that condition. Actually, behavioral intervention has been shown to be able to be a bit more effective even than the medications we would prescribe for that particular condition. So when people go to treatment, people may expect what medication did they place you on, what form of MAT, but they may not have been placed on a form of MAT. They may have been placed on a medication to help their psychosis, to stabilize their mood, to help their sleep, but nothing directly that affects their craving. At my practice, we use a combination of things that we try to customize for clients to be able to help them reduce their cravings and some of the symptoms associated with its use.
And speaking about that, in people with both addiction and mental illness, how does MAT support stabilization so therapy, trauma work, and even psychiatric treatment can actually be effective?
When we think about people with dual diagnosis and if they are having ongoing struggles with withdrawal, it's kind of hard to focus on, looking at, problem solving, coping, managing these trauma triggers. It's hard to have any focus on that when people are physically sick, right? So MAT at the beginning has a place of being able to stabilize that. But even after people are no longer going through withdrawal, we have to find a way to reduce their cravings. Without the reduction in cravings, for a lot of people, not all, but for a lot of people, it is difficult for them to stabilize their anxiety or their depression. And it, allows for, increasing challenges for the antidepressant, the mood stabilizer, or the other medication to do what it needs to do if people feel continually overwhelmed with cravings. So to be able to interject, MAT while they're on their antidepressant, while they're on their mood stabilizer, while they're receiving individual therapy where they're not distracted by those thoughts and impulses to use, it allows for both of these things to work together at once, as opposed to waiting for one or the other to be stabilized to start. So.
Absolutely. And speaking about all these different scenarios and all these different people who may have different disorders and conditions, is MAT appropriate for everyone?
Mm.
And how do you really evaluate who is a good candidate? And how do you really individualize treatment rather than using a one size fits all approach for anyone who is a good candidate for MAT?
First of all, what are your goals?
Mhm.
What are your goals in getting well? And for some people, I just want to be able to take something so I don't feel sick so I can move forward. And for those individuals, for sure, Matt has a great place in being able to stabilize the withdrawal symptoms. They get them physically and mentally feeling better, and then we can make some next steps from there. For some people, do not want medications to be a part of their journey. The evidence supports that with what happens to the brain and how well these medications work, that it should be an option that's offered to everyone and then everyone kind of make their decision about how they want to proceed with their recovery. But some people decide that they don't want to do medications, and those individuals sometimes are able to move forward with health and wellness and manage their recovery. That does happen, right? But by and large, most individuals would benefit from that. So things that we look at are their overall health, the health of their liver, their ability to be able to take a medication each day. How much supervision do they need in being able to take their medication? Those things play a part, in being able to make some decisions around, if they should take MAT and what form of MAT may be best for them.
Absolutely. And for people of faith, right, Matt can raise some spiritual or moral questions. So,
Yeah.
how do you help patients really reconcile faith or personal responsibility and medication without shame or conflict?
Yeah. What I say, and which is what I believe, is that God has given us these options. Some grandmother was praying somewhere, help my grandson with something to help him to get better. And God has given us these options to be able to help people. The disease that probably in my mind resembles a great deal when we think about substance use disorder is diabetes.
Oh, yeah.
Diabetes, sometimes you can have a genetic risk for diabetes, right? It kind of determines the course, much like you would have for some people who have substance use disorder. But a lot of what we see with diabetes comes from, things that are involved with our lifestyle, how we eat, how we don't take care of ourselves, how we don't exercise. And those things increase the risk factors for diabetes. And then we have to take an injection, a medication, insulin for many people. We have to replace that so that people's bodies can be stabilized. When we have substance use disorder, it's a condition that people may have genetic risk for, right? But there are some decisions, unfortunately, that have been made with maybe a compromised brain that allows for them to now develop this chronic illness. And this chronic illness often requires medication, often a replacement medication that allows for the brain to function a bit better. We would not shame someone for taking insulin or the medications necessary for them to be euglycemic or have stable blood sugars so that they can function and not suffer complications. And we shouldn't, create stigma and shame for people who have this, chronic medical condition who also need a medication to help to be stabilized, particularly in the brain. So that I see them very similar, and I try to create that analogy when I talk to families, community groups, and clients about receiving care.
Absolutely. And I think that another question that's really big when people are starting MAT or for families that have someone that's starting MAT, how long will someone have to be on MAT? And how do you really think about duration and tapering and even long-term planning without creating a fear or pressure, even some sort of resilience within that person?
I, allow that client or that patient to make that decision.
Mhm.
I don't say that this has to be a time limited thing. When we think about time, the only one that has been really tied to time to some degree is Vivitrol. And when we think about alcohol, and they introduce the concepts maybe of 6 months, right? But we've had people who've been on Vivitrol for much longer periods of time. I've had patients who decided to be on MAT and they were only on MAT for a few months and they wanted to taper, and we assisted them with tapering while they're in treatment, getting a great deal of structure and support, right? All those things are necessary for this part of the journey. And they were able to have success. But I've also had people who've been on MAT for 10 years, who've been able to go from a place where they weren't able to maintain their families nor themselves, and they were treated, and that treatment involved MAT, and now they're sending their kids off to college. And so everyone's journey with that is different. And I allow for the patient to kind of take the lead and where they want to do with that, providing them some counseling and some education. Hey, these are the risks, and these are what we can do to reduce those risks. But everyone's journey is different. So I don't try to put a time limit on someone being on MAT, much like I wouldn't want to put a time limit that someone is on insulin, if they struggle with diabetes.
Absolutely. And I have another question just based on that as well. What does effective integrated mat based treatment actually include beyond the prescription itself? Because I
Yeah.
know that's a big part of it as well.
So, yes, there's a medication, but attached to that is the person who's prescribing the medication. And so that person not only should be making sure that you're on the lowest effective dose of that medication, but they're looking out for all the other systems that are affected by substance use disorder or side effects. So they're kind of walking through those things. But there should be a counselor. There should be someone who is problem solving with the client, giving them tools to be able to cope, addressing depression, anxiety, or any other, psychiatric or mental health condition that may be alongside this. And then oftentimes there should be a community. That community can be within the treatment group that they're attending, or it's the community at large, which they are part of, which could be their support system, their recovery groups like AA, NA, Smart Recovery, Celebrate Recovery, and of course, all the things that allow for us to progress with life, period, which means vocational coaching, helping us get, with a job, and then whatever systems are necessary for us to maintain our family. We think about the big picture. That's really all the things that should be surrounding MAT. Some people are able to start MAT with just taking the medication and they go for it on their own. And people have some success, but the greater success and the conditions for which these medications were studied were people who were receiving significant amount of psychosocial and treatment support.
Absolutely. I think that is so important. We've talked about that in previous episodes too, about having the right support. And I think also there is so much stigma around this, but it's so important to have these conversations because Matt isn't about taking the easy way out at all. It's really about giving the brain a chance to stabilize so healing can really begin. And as Dr. Moss shared today, recovery isn't one tool or one decision. It's a thoughtful and compassionate process that really treats the whole person.
Mhm.
And I think it's so important, I can't stress it enough, to have these conversations and really share this information because someone probably knows someone who's struggling, or maybe someone listening is struggling, and just shed a whole new light on what's possible and how recovery is possible. And if today's episode really helped clarify or challenge your thinking in any way, please make sure you follow the complete reset so you don't miss what's next. Dr. Moss, I can't thank you enough for this episode. And is there anything else you wanted to say at all?
I will say this just real quickly. There are many people who judge people who are on MAT.
Mhm.
And there may be people who are in recovery themselves saying, I was able to establish my recovery 20 years ago. And I did it without medications, and you should be able to do that too. Everyone's journey is different, right? And I respect those who decide they don't want to have any form of MAT. But what I will say is that the drugs that were used 20 years ago are very different than the drugs that are being used now. The potency is much higher. The effects on the brain are a little bit different. So the brain in recovery now is very different in the challenges that it faces compared to the brain that was using 20 years ago. So.
Absolutely. And I think that that's important that you mentioned too, because like we talked about, there is stigma that goes along with it. And a lot of that, which we've also talked about, there's so many new ways in treating people that have developed, but a lot of that thought process is based on older ways of treating people. And there's so much new information, and there's going to continue to be new
Yeah.
ways and information. It's something that's always evolving because this is a condition like we talked about. So that was a very, very good thing to mention as well. And I love these conversations with you. I think this was another great episode, and I can't wait to talk to you soon so we can continue this conversation. And there's a lot of other great topics we're going to dive into. So, also, everyone listening, make sure you do subscribe and follow. And Dr. Moss, I can't wait to talk to you soon. We'll talk soon.
Hey, take care.
Have a good one.